Assalamu alaikum, dear viewers. My name is Nakshabandi. Today I'm going to continue with you the series of universal topics, and today we're going to highlight some important aspects about post-operative care. The learning objectives of this talk would be to devise a post-operative care plan, to show how to hand over the patient properly to the appropriate facilities, to describe the process of post-operative recovery in a patient, and to identify common post-operative complications, and to monitor patients for possible post-operative complications, and to institute immediate management for post-operative complications. The post-operative period starts as soon as the patient leaves the operating table under the direct supervision of the anesthetist, and it includes the period of transfer from the operating theater to the recovery ward, and the patient must be supervised and monitored closely at all times by the anesthetist. Now I'm going to explain to you the component and important features of post-anesthetic care unit, which is called the PACU. First of all, the personnel. They need to be trained and experienced nurses. One nurse must remain with each patient at all time until consciousness and airway reflexes returns. And anesthetist should be always immediately available to treat complications detected by the nursing staff in the PACU unit. What about equipments? All PACUs should have beds and trolleys which have the facility to be tapped down immediately. A suction apparatus is very important, an oxygen supply, monitors such as the pulse oximeter and the non-invasive blood pressure monitoring, resuscitation equipments, and at least one mechanical ventilation. What about medication? A wide range of medications or drugs should be stored for the treatment of common complications and also emergency events. Dosing charts and dose calculators should be always available and reachable for any immediate use. How does the handover takes place in the PACU? In the recovery ward, the anesthetist should give the nurses and doctors full details of the pre-existing medical problems, the surgical procedures, the anesthetic technique, the drugs utilized before, during, and after the procedure, regional blocks, fluid blood loss or replacement, and untowards events and any anticipated problems during the recovery. This should be done in a systemic fashion and undertaken in an unhurried way. They should be done after essential monitoring, and the anesthetist should not leave the patient until being satisfied that there are no immediate problems, especially the airway, respiratory, and cardiovascular systems. What are the essential monitorings in the PACU? Pulse rate, arterial blood pressures, oxygen saturations, respiratory rate, assessment of the level of consciousness, peripheral circulations, and adequacy of ventilation. Additional monitoring may be required based on the surgical intervention and the status of the patient, such as ECG, CVP, invasive arterial pressures, partial pressure of carbon dioxide, especially during after tracheal intubation. Wounds and surgical drains should always be inspected regularly for signs of bleeding, and recording of physiological measurement should be made every 5 minutes until consciousness has returned, and then at an interval of 10 to 15 minutes. It's very important to document any event during the presence of the patient in the PACU unit, and a record should include the vital data, level of consciousness, the pain scoring, sensory level, complications, if any, drug and fluid administration, and any other relevant information that might be needed. All right, before discharging the patient from the PACU, these are few recommendations that need to be taken in consideration. The patient should not be discharged to the surgical ward until the following criteria have been met. The consciousness has returned fully, the patient airway can be maintained and protective reflexes are present, ventilation and oxygenations are satisfactory, the circulation is stable with heart rate, Arterial blood pressure is approximate to the preoperative value with no unexplained cardiac irregularity or persistent bleeding. Peripheral perfusion is adequate. Pain and nausea are well controlled or absent, and the temperature is within the normal acceptable limit. What are the additional considerations that need to be taken before discharging the patient? High-risk patients or those who have undergone major surgery may need to stay in the PACU for up to 24 hours. And if this is not feasible, or if the instability persists for longer than 24 hours, the patient should be transferred to a high dependency unit or an intensive care unit. The level of monitoring and care during transfer should be the same as that in the recovery room. Although the recovery room nurse undertakes the direct care of the patient, the responsibility for the patient remains with the anesthetist. Patients must only be discharged to the ward with the anesthetist's consent. What is the common post-operative complications? And I'm going to highlight a few about how to diagnose, to have a differential diagnosis and management of common conditions. First of all, the pain. Severe post-operative pain and the stress cause an increased morbidity and mortality. And the origin from this can be related to the cardiovascular system, respiratory system, or gastrointestinal system. If the pain persists, there will be an increased myocardial oxygen consumption and demand, and this might lead to myocardial ischemia. And this also will lead to a reduced mobility, venous stasis, and increased clotting, which might lead to a venous thrombosis. What about respiratory factors? The pain might lead to weakened cough, reduction in lung volumes, atelectasis, and sputum retention, which later on might complicate the post-operative recovery phase with chest infections and hypoxemia. Pain can lead to a delay in gastric emptying and reduced intestinal motility, which might be very discomforting for the patient in the post-operative recovery period. Pain also can lead to urinary retention, which might affect the genitourinary tract, and it might also lead to a metabolic and endocrine disturbances. This can be observed by the release of vasopressin, aldosterone, renin, angiotensin, cortisol, glucagon, growth hormone, and catecholamines. And it will also, the pain, lead to a reduction in insulin and testosterone, which might lead to an increased breakdown of protein, which might impair the immune system and delay the wound healing and lead to a sodium and water retention. Chronic pain in the post-operative period can can complicate the acute phase, and the patient will have a sort of a chronic pain problem. Also, the pain can lead to a psychological factor, which will usually lead to a patient anxiety, sleeplessness, fatigability, and distress. So it is very important to assess pain in the post-operative period. There are a few assessment tools that can be utilized. The first one is a verbal rating scales, which classifies pains into mild, moderate, or severe. This is an easy procedure for patients, and it is less suitable for research purposes. A second rating scale is the numeric rating scales, which takes two extremes of pain experiences, have a numerical scale in between, making no pain and worst imaginable pain on the scale, and this can be easily reproducible and easily for the patient to understand. A third assessment tool is the visual analog scales, which is similar to the numerical rating scales with two extremes of the pain experience on either end of the scale, and this can lead to a generation of continuous data and make analysis easier than with verbal or numerical rating scales. Examples of what we have mentioned is the numerical scale, which is rated from 0, where there is no pain, to 10, which is the worst pain, and this can be also interpreted with some visual cues that the patient can easily understand. How we manage usually acute pain post surgical intervention? The World Health Organization had developed a sort of an analgesic ladder for acute pain management. And usually we can start with non-opioid plus minus any adjuvant therapy. And if the pain persisted or increased, an opioid for mild to moderate pain can be added. And if the pain persisted, opioid for moderate to severe pain can be increased with the possibility of adding non-opioid or adjuvant therapy. Now we're going to speak about a couple of important classes of medication that is commonly used in the post-operative period. First of all, the paracetamol. It inhibits the prostaglandin synthesis within the central nervous system and leads to an analgesic and antipyretic effect without any anti-inflammatory activity. Usually it is excreted in the urine after hepatic metabolism, and the overdose of these medications can lead to hepatic cell necrosis. They are usually given in an oral route or a rectal route, but it's also available as an intravenous preparation. The recommended dosage for it is usually 4 grams per day for adults, and it is most effective when prescribed regularly rather than on a PRN scale. The second group of common analgesics, are the non-steroidal anti-inflammatory medications. They have an analgesic, anti-inflammatory, antiplatelet, and antipyretic effect. The mechanism of action usually by inhibition of cyclooxygenase enzyme, and consequently the synthesis of prostaglandins, prostacyclins, and thromboxane A2. The selective COX-2 inhibitors may be associated with a fewer GIT adverse effect than the COX-1 and COX-2 inhibitors, and may be used as the sole analgesic for mild to moderate pain. Side effects with non-steroidal anti-inflammatory drugs are relatively common and need to be always taken in consideration. What are the contraindications to non-steroidal anti-inflammatory drugs? It's very obvious: history of GIT bleeding or ulceration, a known hypersensitivity to these medications, severe liver dysfunction, heart failure, dehydration, hypovolemia, hypotension, hyperkalemia, or a pre-existing renal impairment, uncontrolled hypertension, or aspirin-induced asthma. Third common group of medication that usually utilized in the post-operative period for control of pain are the opioids. The agonist they usually works by antagonizing opioid receptors found mainly in the brain and the spinal cord, and have a similar spectrum of side effect with inter-patient reliability. The major adverse effects are respiratory depression, which is most feared, nausea and vomiting, which is most distressing for a post-operative patient. Also, they might lead to sedation, dysphoria, muscle rigidity, meiosis, constipation, and pruritus. How can these opioids be administered? They can be taken orally, or they can be prescribed as an intermittent subcutaneous or intramuscular, or they can be prescribed as an intermittent intravenous. The oral formulation have a limited bioavailability due to the first-pass metabolism. They lead to immediate release. The immediate release of oral opioids are preferred for early management of acute pain, and the slower onset and longer duration of controlled release formulation make rapid titration impossible with the oral formulation. For that reason, we resort to the intermittent subcutaneous or intramuscular, which is the traditional route of administration, and usually it is ordered on a PRN basis. It might lead to fluctuation in blood levels, so if there is a need for a steady level, an intermittent IV dose can be utilized, and this can lead to a small, suitable relief of pain in the post-operative period and maintenance of analgesia, but it will need a trained staff, and commonly used regimen are the morphine 1 to 3 milligrams or the fentanyl 20 to 60 microgram every 5 minutes until the patient is comfortable. With a continuous IV infusion, it is important to avoid peaks and troughs in the blood levels and need to close observation and monitoring as we mentioned. Patient-controlled analgesia is referred to as self-administration of IV opioids, which we're not going to explain about it because it's out of the scope of this talk. Intrathecal Opioids can be used during spinal anesthesia. Intranasal are very effective in children older than 1 year of age. And transmucosal, especially the fentanyl lollipops, can be utilized in children during the anesthetic premedication. And also transdermal fentanyl patches are available for chronic pain. What are the common opioids that we utilize nowadays? Morphine is the gold standard against which all new analgesics are compared. It has the least lipid-soluble opioid, and it is mainly metabolized in the liver, and the dose ranges and dose intervals vary according to the route of administration. Fentanyl is the second common used opioid. It has a high lipid solubility with a short duration of action. Its metabolites are inactive, and fentanyl is commonly administered intravenously, epidurally, or intrathecally. The high lipid solubility make it suitable for transdermal administration as well. The third group are the pethidines. They have an analgesic with anticholinergic effect and some local anesthetic action as well. They are metabolized in the liver with metabolites excreted in the kidney. And norpethidine is a metabolite potent analgesics. So high blood concentration can lead to central nervous system excitation, and patients with impaired renal function are at a high risk of developing this side effect. This is a table which compares opioid equivalent analgesic doses, and as we say that morphine, fentanyl and pethidine are the three common opioids. They can be given intravenously or intramuscularly, or they can be given orally except of fentanyl. Now we move to the central nervous system post-operative complications. The usual anticipation for a post-operative complication related to the central nervous system are either impaired conscious level, confusion and agitation, or pain. What about impaired consciousness? Many patients are unconscious on arrival in the PACU unit because of the residual effect of the anesthetic drugs. The duration of impaired consciousness depends on the drug used, the timing of the drug used, and the pain perception. So what are the possible causes for these impaired consciousness? As we mentioned, impaired effect of anesthetic drugs, hypoxemia, and hypercapnia are among the common causes for this. Additionally, hypertension, hypothermia, hypoglycemia or hyperglycemia, cerebral pathologies, and other surgical-related causes such as the TURP syndrome or hypothyroidism or hepatic and renal failure might be anticipated. How we can manage an impaired conscious level? First of all, we want to make sure that the airway is patent. The patient is breathing adequately and the circulation is maintained. Then we need to seek and find the reason and correct it promptly, such as to check for the blood glucose or correct any other abnormalities that might lead to impaired consciousness. What are the respiratory post-operative complications? These can be classified into three groups: hypoventilation and hypoxemia, atelectasis, or pneumonia. We start by hypoventilation. Hypoventilation results in an increase in the partial arterial pressure of CO2 and a decrease in the partial arterial pressure of oxygen. And thus this leads to hypoxemia, which might be corrected by an increasing a forced inspiration of oxygen. The risk factor for developing hypoventilation include old age, obesity, prolonged surgical operations, opioid use, or upper abdominal or thoracic surgery. So this table highlights the three possible causes for hypoventilation. As we mentioned, the airway, so we need to assess the upper airway and relieve any airway obstruction. Make sure that the tongue is not obstructing the airway. There is no laryngospasm, there is no edema, there is no bronchospasm. Then we need to make sure that the central causes are also assessed well, such as any drugs that might lead to respiratory depression or hypothermia, or preoperative central nervous system pathology or cerebrovascular accident. Also, peripheral causes might lead to hypoventilation, such as residual neuromuscular blockade, pain, abdominal distension, electrolyte abnormalities, obesity, or tight dressing, or anemia or hemothorax. We will focus now on upper airway obstruction. Usually it is caused by the tongue and by indrawing of the pharyngeal muscles or by blood or secretion in the pharynx. And this might lead either to a partial or total obstruction. Partial obstruction can be characterized by noisy breathing with tracheal tug and indrawing of the supraclavicular area. And total obstruction is signaled by absent sounds of breathing and a paradoxical movement of the chest wall and abdomen. It's very important to manage these post-operative problems related to upper airway obstruction. First of all, we need to place the patient in the lateral or recovery position and to maintain the airway. We might utilize some airway devices to help us do that, such as the oropharyngeal airway, nasopharyngeal airway, laryngeal mask, and tracheal intubation. However, some of these devices might itself cause more deleterious effect on the airway obstruction. This is a common maneuver, which is the head tilt and chin lift, with sometimes the jaw thrust, which can visualize the airway and prevent any obstructing causes for impairment of airway patency. The second cause for a possible hypoventilation is laryngeal spasm, and this is relatively common after general anesthesia, especially in children undergoing oropharyngeal surgery. It might be partial or complete, and it might be caused by direct stimulation of the cord by secretions or blood, or of the epiglottis by an oropharyngeal airway or laryngeal mask. How do we manage it? First of all, we need to remove any foreign material, such as blood or secretions. Give an oxygen at 100% rate. Start positive pressure ventilation by mask to maintain oxygenation until the spasm subside. We might utilize small doses of succinylcholine if attempt to oxygenate the lung fails. We need to maintain ventilation, and if all these measures failed, a tracheal intubation may be advisable. What about diminished respiratory drive? As we mentioned before, the commonest cause for this is drug that we utilize. All inhalation and anesthetic except nitrous oxide might lead to this. All IV anesthetic agent can lead to this except ketamine, and all opioid, especially in an elderly population. Also, a common cause for diminished respiratory drive apart from medication is hypothermia, and this is mainly seen in children. So how to manage it? With mild hypoventilation, usually this can resolve spontaneously. We need to maintain adequate oxygenation to prevent any hypoxemia or hypoxia. And if there is no severe increase in partial arterial pressure of carbon dioxide or no delayed recovery, we can monitor it till it resolves. It's very important to mention that an increasing in FiO2 in hypoventilation will not work unless the cause is corrected promptly. If the ventilatory drive is reduced excessively, resulting in any of the following, such as hypoxemia or hypoxia, severe increase in PaCO2, or delayed recovery or impaired consciousness, the following management can be taken. Naloxone can be given at a rate of 1.5 to 3 microgram per kilogram IV and can be repeated every 2 to 3 minutes until improvement occurs. In order to prevent this from happening, it can be repeated at 50% of the effective IV dose and may be administered intramuscularly or an IV infusion fashion. Residual neuromuscular blockade, also a common cause for hypoventilation, and this is actually the commonest non-central factor associated with hypoventilation. It may be exaggerated by neuromuscular junction disease such as myasthenia gravis or electrolyte disturbances, and usually it is associated with uncoordinated or jerky movement. It's very important to assess the adequacy of antagonism of neuromuscular block, and this can be assessed by the grip strength adequate cough, ability to sustain head lift for at least 5 seconds, ability to produce viral capacity of at least 10 ml per kilograms, or by nerve stimulation, which is the most sensitive technique. How do we manage it? Additional doses of newstigmine, up to total of 5 milligrams, or in case of the usage of rocuronium or vancomycin, we might use Sagamedex at 2 milligrams per kilogram. If the block persists and there is no improvement of the muscle power, it's best to resort to tracheal intubation and artificial ventilation to make sure that we evaluate the cause and provide anesthesia to prevent any awareness. What are the commonest cardiovascular postoperative complications? These can be listed into the following: hypertension, arrhythmias, conduction defects, myocardial ischemia, deep venous thrombosis, or pulmonary embolism. Hypertension is mainly caused by the residual effects of anesthetic drugs, or by hypovolemia, or by arrhythmias. It is less commonly caused by ventricular failure or sepsis and shock. If we're suspecting a residual effect of anesthetic drugs, the residual vasodilator of IV or inhalation and anesthetic drugs are the usual causes for this. Sometimes the subarachnoid or epidural anesthesia also might lead to this hypertension, and up to 20% decrease in the mean arterial pressure is tolerated well, except by the elderly or patient with myocardial disease. So how do we treat patients with residual effect of anesthetic drugs? Usually no treatment is required in most patients. Elevation of the legs often increases arterial pressure by increasing venous return, and sometimes intravenous infusion of colloid solution are effective in restoring normal tension. Hypovolemia is another culprit for hypotension, and this might be the consequence of inadequate or inappropriate replacement of preoperative or intraoperative fluid and blood losses, or from postoperative hemorrhage. So it's very important to evaluate surgical bleeding, and it might be obvious from inspection of the wound and drains, but may be also concealed, particularly in the abdomen, retroperitoneal space, or thorax, or even when the drains are present if they are blocked. Hypertension caused by hypovolemia may be accompanied by signs of poor peripheral perfusion, such as cold, clammy extremities and pallor. Tachycardia may be present, but is masked usually by the effect of medications. Hypovolemia can be managed immediately by elevation of the leg, appropriate use of crystalloid or colloid solutions, administration of red blood cells, clotting factors, or platelets, and the surgical bleeding may be treated by reoperation if necessary. We come now also to a common encounter that we usually found in the post-operative period, which is the nausea and vomiting. The incidence of this happens in up to 30% of all patients undergoing general anesthesia, and up to 80% in high-risk patients. This might lead to a decreased patient satisfaction, delayed hospital discharge with unexpected hospital admission, wood dehiscence, bleeding and pulmonary aspiration, and also fluid and electrolyte disturbances. What are the risk factors for developing postoperative nausea and vomiting? Female gender by itself is a risk. Previous postoperative nausea or vomiting or motion sicknesses, non-smokers, and the use of perioperative opioids. If one of these factors is present, up to 20% will develop postoperative nausea and vomiting. This can go up to 40% if two factors are present, and this can increase to 60% if three of these factors are present, and it can reach to 80% of patients if four of these factors are present. What are other factors associated with postoperative nausea and vomiting? Breast and gynecological surgery, ophthalmic surgery, specialist strabismus repair, ENT procedures, laparoscopic, and craniotomy procedures, especially on the posterior fossa. Other factors that might contribute to postoperative nausea and vomiting are, as we mentioned, opioid use, nitrous oxide and inhalational anesthetic agents, intravenous anesthetic agents except propofol and dehydration. How do we manage it? We need to anticipate this and prevent it from happening. So regional anesthesia are less likely to cause this compared to general anesthesia and should need to be utilized whenever possible. If general anesthesia is mandatory, a total intravenous anesthesia is better than the inhalational anesthetic agent, and it's better always to avoid nitrous oxide and to have adequate hydration of the patient. If this happened, first of all, we need to reassure the patient. We need to correct the vital signs and ensure adequate analgesia and hydration control. And we might use antiemetics. And the combination of antiemetic therapy is very effective in the post-operative period. This table will highlight some of the commonly used antiemetics. The hyoscine is usually given if a patient undergone posterior fossa surgery or if an opioid-related nausea occurred. Cyclizine also can be utilized in patients who have opioid-related nausea. The same is true for chlorperazine or metoclopramide. Ondansetron is very effective on pediatric patients because it's the first line of management of nausea and vomiting, and it has a reduced side effect compared to other medications. Dexamethasone is not usually used as a sole agent, but it can be combined with other medications. These are some of the references for any further reading. Thank you very much and wishing you the best of luck.